Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. How comfortable are you in a code situation? Do you run away and hide, or do you jump in and refuse to leave? I am the latter. I always want to be there to help bring someone back to life. I guess you can say resuscitation is my jam. Ask anyone I used to work with when I was an RN. Wherever there was a code in the hospital, I was there. I have witnessed excellent codes and some not so good ones. With all of my experiences, I decided I needed to create this presentation to help nurses level up their resuscitation game. The objectives of this video are to understand the need for advanced resuscitation management, identify what a resuscitationist is, identify common mistakes and pitfalls during cardiac arrest resuscitation, recognize problems with conventional ACLS guidelines, and discuss alternative therapies to consider for advanced cardiac arrest resuscitation. It is really dismal that survival rates for in-hospital cardiac arrest are only around 25%. Survival rates for out-of-hospital cardiac arrest are even poorer at 10%. There's a commonly held belief by healthcare members that a patient in cardiac arrest cannot become more dead, so we haphazardly throw the kitchen sink at them hoping to achieve ROSC. While I think this belief isn't wrong per se, I do believe doing a few more right things and a few less wrong things can improve these horrible ROSC rates. A well-trained resuscitationist brings a higher level of expertise to the management of cardiac arrest beyond standard ACLS algorithms. Many nurses have their ACLS certification and believe they are now highly trained for resuscitation. Sorry to burst your pride bubble, but despite it being called advanced, it is anything but. Many of you might be surprised to know that the American Heart Association publishes a very lengthy document every few years that reviews the available evidence for tons of different resuscitation interventions. There are many advanced therapies, techniques, and strategies that exist with reasonable evidence to support their use, just not enough to be included in ACLS as the standard of care. I know this slide is difficult to read. It was taken directly from the AHA. It explains the class of recommendation and level of evidence for all of the guidelines they discuss. So, I mentioned earlier that a good resuscitationist brings a greater expertise to the table. But what is a resuscitationist? A resuscitationist is any medical practitioner whose primary motivation is to provide high-level, expert resuscitation care to acutely ill patients. Naturally, we assume this to be physicians, but a resuscitationist can include nurses, RTs, pharmacists, EMTs, etc. Anyone who brings their highest level of expertise and skill to resuscitation efforts. I think it's worth mentioning that critical care does not necessarily equal resuscitationist. Emergency medicine does not equal resuscitationist. Anesthesia doesn't equal resuscitationist. We all know a doctor or nurse or RT who might work in the ICU but don't really perform the greatest during codes. A true resuscitationist is one who is passionately dedicated to perfecting their resuscitation craft. It's like any other skill or service you seek out. Naturally, you're going to want someone who is the best in that field. You want someone so good at their craft, their name is synonymous with it. All of these professionals are some of the best in their field. Does anyone recognize this man? If you do, you might be a resuscitationist. This is Dr. Scott Weingart, the founder of the MCRIT podcast and the inspiration for this YouTube channel. I have been listening and learning from him for many years. In the medical world, his name is very much synonymous with resuscitation. If you are sick and dying, he is who you want to be your physician because he is passionately dedicated to mastering resuscitation. Now on to the first part of the presentation. After being in countless codes, these are some of my observations of the most common mistakes that are made. I will also go over several myths and misconceptions that people have regarding some of our common practices. There are a lot of things we do without good evidence and often have been demonstrated to do more harm than good. But mistakes help us grow, so let's review and learn. Here is a general list of the most common mistakes and pitfalls I have personally witnessed during resuscitation. The first common mistake is that staff panic and frantically accomplish nothing. It's silly, but I've seen it, especially in codes outside of the ICU. Everyone is running around and not a single thing gets accomplished until someone commands the room. Next, lack of 30-2 ratio before the patient is intubated. I don't know if I have ever seen anyone count to 30 in the hospital while doing compressions. They just do continuous compressions and RT will bag intermittently. But without an advanced airway, that mask bagging probably isn't accomplishing much. But hey, I guess it's better than nothing. This one is not as common per se, but I have seen epinephrine given every 2 minutes instead of every 3 to 5 minutes. For simplicity of timing, I recommend you give epi every 4 minutes, which coincides with every other CPR cycle. Every 2 minutes, someone calls for a pulse check. It's actually supposed to be a rhythm check. We only check for a pulse if that rhythm is perfusable. We don't check for a pulse every time if the rhythm is shockable or asystole. The next horrible mistake is the defibrillator is not pre-charged before the rhythm check. You should be charging about 15 seconds before the rhythm check so you can instantly shock for VT or VF. Do not wait to start charging after you identify a shockable rhythm. Compressions are not resumed immediately after shocks. You're not supposed to shock and then wait to see if it worked. You just immediately resume compressions. Even if the heart's electrical rhythm is restored, understand that the myocardium is still stunned and not contracting properly. Continuing CPR gives it a couple more minutes to recover its pumping ability. Compressors are switched out before the 2-minute cycle is complete. As much as possible, we want uninterrupted chest compressions, so if you have someone who cannot last the full 2 minutes and you have enough staff, just take them out of the rotation. It really disrupts the flow and efficacy when staff are changing out on their own without direction. Compressions are held during intubation. Yikes. CPR is the highest priority in cardiac arrest, and the provider needs to try to intubate through the compressions if possible. I sadly have seen lesser skilled physicians pause CPR for over a minute while trying to intubate. Most BVMs are missing a PEEP valve. A small amount of PEEP is so important for inflating the lungs during ventilation, but using high PEEP levels may worsen cardiac output, so use it cautiously. Ventilations are often too deep and too frequent. Remember to only squeeze the bag every 5 seconds and only use one hand. Squeezing with 2 hands will deliver way too much volume and overdistend the lungs and possibly induce an alkalosis. And the last mistake is relying too heavily on intraosseous access. Even if you get emergency IO access, someone should still be trying to get an IV during the code. IO is acceptable, but IV is best. On to everyone's favorite, non-evidence-based drug, sodium bicarbonate. Has anyone ever been in a code where bicarb wasn't given? Anyone? I once saw a code where nurses pushed bicarb before even grabbing the epi, which, by the way, is not in the ACLS algorithm, so those nurses were not exactly covered for their actions. The AHA states that the routine use of sodium bicarb is not recommended for patients in cardiac arrest. That doesn't mean you should never give it, just make sure you have a valid medical reason for giving it. Tricyclic antidepressant or sodium channel blocker overdose, hyperkalemia, or known metabolic acidosis. Don't just assume your patient is acidemic without confirmatory testing. One thing to note is that when bicarb is rapidly pushed, there will be an expected transient spike in end-tidal CO2. This does not necessarily indicate clinical improvement and may confound your resuscitation efforts. The better end-tidal readings you see are not from better quality chest compressions, it's just a chemical reaction from the bicarb. The other two willy-nilly kitchen sink drugs are calcium and magnesium. The AHA states that the routine use of calcium or magnesium for cardiac arrest is not recommended. Although calcium can augment cardiac contractility and help vasoconstrict arteries, it hasn't been shown to improve outcomes. It should only be given for calcium channel or beta blocker overdose, or for confirmed hypocalcemia, hypermagnesemia, or hyperkalemia. I suppose you can also consider it for someone who has received a buttload of bicarb, since bicarb can lower ionized calcium. Similarly for magnesium, there is no proven benefit except when used for torsade de pointe, hypomagnesemia, or digoxin overdose. We use many drugs during resuscitation, and most nurses know why we give these meds, but many do not realize that all of these meds come with some significant problems. Imagine stacking all of these adverse effects onto each other. We think it's okay to give 10 amps of epi in the name of saving a life, but the more we give, the worse we may actually be making things. Like everything else in life, it's about balance and moderation. More is not always better. The next topic of errors and pitfalls is the assessment of resuscitation efforts. Clinicians often use the presence or absence of pulses and/or arterial blood gases during chest compressions to assess the adequacy of our artificial perfusion. Sometimes doctors or nurses will keep their fingers or Doppler in the groin to check for a pulse with compressions. But interestingly, because the inferior vena cava has no valves, retrograde blood flow may occur in the femoral vein during compressions. When you palpate or Doppler the femoral area, you may be detecting a venous rather than an arterial pulse. Studies have been conducted, and up to 50% of the time, it's a venous pulse. So I would say don't even bother checking for a pulse with compressions. It's just too unreliable. Arterial blood gases do not reflect tissue pH and PCO2 and should not be used to assess adequacy of CPR efforts. An ABG tends to make the patient look better than they are. Venous gases better represent tissue physiology. Presently, waveform capnography remains the best non-invasive technique for monitoring cardiac output during CPR. However, it is important to recognize iatrogenic variables that can affect the readings like bicarb administration, epinephrine, hyperventilation, etc.
Somebody get Lucas! Who's Lucas?
Some hospitals have access to mechanical CPR devices. One such brand is LUCAS, which is an acronym that stands for Lund University Cardiac Assist System. These devices are amazing, but far from perfect. The advantages of using a mechanical CPR device are it provides consistent quality chest compressions with increased compression fraction. It allows for extended CPR times. You can provide CPR during transport. It frees up multiple staff members from having to do compressions. It reduces provider injuries. And most importantly, it reduces scene chaos. But despite these amazing qualities, these devices also have some major cons. First, most of the current evidence doesn't demonstrate superior outcomes when compared to hand CPR. I have seen them cause significant skin and/or musculoskeletal trauma. We know how important it is to minimize chest compressions, and the device can take considerable time to set up if the team is inexperienced. Lastly, it creates a set it and forget it mindset. What I mean by this is that once the device is deployed, no one questions its efficacy. They assume it's the highest quality of compressions available. But emerging data suggests that the traditional internipple line placement for compressions may be obstructing the LV outflow tract in a significant amount of patients. Even with a poor end-tidal CO2 reading during compressions, I have only rarely persuaded a physician to switch back to hand CPR, which is much easier to readjust to the optimal compression site. Like hand CPR, mechanical CPR should be constantly reevaluated for effectiveness during resuscitation. Based on the available evidence, the AHA states that mechanical CPR devices may be considered in specific settings where the delivery of high-quality manual compressions may be challenging or dangerous for the provider, as long as rescuers strictly limit interruptions during deployment of the device. But overall, the routine use of mechanical CPR devices is not recommended. I put mechanical CPR in this first half of the presentation not because it's a mistake or a pitfall, but to bring attention to the fact that there are significant downsides with its use. But if you are an expert center that can rapidly deploy the device and diligently monitor its effectiveness, I think you can continue using your device. Have you ever seen bad things happen right after intubation? Just remember that intubation is not a benign procedure. Scott Weingart is an airway expert and has several lectures on intubation errors and how to prevent them. Most clinicians can astutely identify the anatomically difficult intubation. However, many do not identify the physiologically difficult one. Dr. Weingart has identified the HOP killers, which are physiologic derangements that can ruin a successful intubation. HOP is an acronym that stands for hemodynamics, oxygenation, and pH, and failure to identify and treat these can be a lethal mistake. Most induction meds invariably drop the patient's blood pressure, so it's prudent to stabilize their BP first. Crank up your vasopressor drips or have push dose pressors handy. If your starting BP is only 70 and you give intubation meds, they will crash and burn. Similarly, with oxygenation, make sure the patient is adequately pre-oxygenated. Intubation can take seconds to minutes. A patient who is in extremis and rapidly consuming every last oxygen molecule cannot tolerate any hypoxemia. For pre-oxygenation, it's recommended to use a BVM with a PEEP valve. Additionally, You can place a nasal cannula cranked up to 15 liters or higher underneath the BVM mask. Once your pulse ox is adequate, you leave the nasal cannula on during the intubation attempt to continue providing apneic oxygenation. Another technique for consideration is DSI, or delayed sequence intubation. This involves using ketamine to sedate the patient without knocking out their respiratory drive and avoiding excessive positive pressure ventilation. The purpose of DSI is really to give extra time for good pre-oxygenation before giving the paralytic and passing the ET tube. In regards to pH, you want to correct acidemia prior to the intubation attempt. In the minute it can take to intubate, that apneic time allows CO2 to accumulate and can profoundly worsen an acidemia to the point of cardiac arrest. Ensure adequate ventilation during the pre-oxygenation period and use end-tidal CO2 to help guide you. Although not practical in most situations, a dissociated awake intubation can be a consideration for patients with severe acidosis. Also, quick reminder, after the patient is intubated, don't set your respiratory rate to the default 16 if the patient was breathing 40 breaths per minute prior to intubation. As I mentioned earlier, intubation is not a benign procedure, and you should have the crash cart readily available. The last mistake I see commonly is not using medications with similar pharmacokinetic profiles. If you choose to use etomidate and rocuronium, the sedative will wear off long before the paralytic, and you will have a patient who is aware and feeling everything but unable to move or communicate. It is borderline malpractice to not provide adequate sedation during paralysis, so remember to choose concordant drugs or start continuous sedation immediately. After we get ROSC on a patient, we are often so amped up on adrenaline we lose focus and forget things. Here is a post-resuscitation checklist of important tasks we should consider. Secure the airway and confirm with a chest x-ray and end-tidal CO2. Consider getting a 12-lead ECG for any out-of-hospital or undifferentiated in-hospital cardiac arrest. Draw standard labs, avoid hypotension and use vasopressors as needed, avoid hypoxia and hyperoxia. Maintain a normal PCO2 and pH, actively prevent fevers, and consider targeted temperature management for those not following commands. Okay, so I already know ACLS. What else is there to know? Well, there are some problems with ACLS in cardiac arrest. Guidelines are based on the best available evidence in resuscitation science, but guidelines are often designed to apply to a general population and do not account for individual differences in patients. ACLS algorithms are designed to guide all practitioners in cardiac arrest management and therefore are simplified as much as possible. It has to be applicable to the resuscitationist as well as the family medicine doc or even psychiatrist. Despite ACLS being called advanced, it really is just the bare bones of cardiac arrest resuscitation. A certified RN can run an ACLS code according to standardized protocols, but a good resuscitation requires an expert who can employ advanced interventions and individualize care to the specific patient in front of them. Perhaps you've been in a code that lasted a long time and just kept cycling through the ACLS algorithm until the patient eventually died. Well, as Albert Einstein has famously said, insanity is doing the same thing over and over again and expecting different results. During a code situation, if the interventions you are doing are not working, try something different. This next half of the video will go over some advanced therapies and techniques to consider when traditional ACLS just isn't bringing the patient back to life. The first practice that is strongly recommended by resuscitationists is placing a femoral arterial line for all cardiac arrests. Arterial pressure monitoring can guide vasopressor titration. You don't need to blindly give epi every few minutes if you know what the BP actually is. You also never need to feel around for a pulse because you will be able to see it on the monitor. If during compressions the diastolic blood pressure never goes above 25 millimeters of mercury, you won't be able to perfuse the heart and will never get ROSC. The diastolic BP should be measured at the beginning of the systolic upstroke as shown in the image above. Do not rely on the numerical value, which will lead you astray. The AHA does say it may be reasonable to use arterial blood pressure to monitor and optimize CPR quality. If you have been a nurse long enough, you may remember that vasopressin was included in the ACLS algorithm but was removed in 2015. But that doesn't mean it can't still be used. Two RCTs in 2009 and 2013 used a cocktail of vasopressin, steroids, and epinephrine during resuscitation and found a statistically significant increase in survival to discharge. The AHA gives a weak recommendation that the combination of intra-arrest vasopressin, epinephrine, and methylprednisolone may be considered. For anyone who thinks this seems like a lame intervention, just remember this actually has a higher recommendation than the bicarb that no one hesitates to give. One of the coolest interventions I have learned about is interposed abdominal compressions, or IAC-CPR. I first discovered this technique on Grey's Anatomy and was thinking, what the fuck is that? Evidently, interposed abdominal compressions have been around for over 30 years already. It involves using two rescuers, one who provides conventional chest compressions, with the other person compressing the abdomen at opposite timing of the chest compressions. The abdominal compression increases pressure in the IVC and aorta. This has the effect of increasing right heart filling pressure and cardiac output, as well as creating retrograde blood flow in the aorta similar to that of an intra-aortic balloon pump. Studies yielded higher ROSC rates with good neurologic outcomes. There were no reports of major organ injury or increased aspiration events, but wasn't studied in those with aortic aneurysms, recent abdominal surgery, or pregnancy. More research is needed, but the AHA says IAC-CPR may be considered when sufficient personnel trained in its use are available. Given how simple this technique is, with potentially high benefits, perhaps this will one day become a standard of care in ACLS. Have you ever been in a code where the patient wouldn't break out of VT or VF after shocking them more than 30 times? This resistance to defibrillation would be considered refractory VT-VF. Or sometimes you successfully shock them out of VT-VF, but they eventually go back into that rhythm several minutes or even hours later. This situation, where the ventricular dysrhythmias recur 3 or more times in 24 hours, is known as electrical storm. Both situations are bad. In addition to standard antidysrhythmic meds like amiodarone and lidocaine, you can consider double sequential, or sometimes called dual sequential defibrillation. This involves using two defibrillators, with one set of pads placed on the typical anterolateral position and another set placed anteroposterior. The two defibrillators are then discharged simultaneously or in rapid succession. It is believed that the electricity hitting the heart from different vectors can more effectively depolarize all the myocytes necessary to restart the heart. The AHA states the usefulness of DSD has not been established, but has it as a weak recommendation to consider. My limited personal experience with it has also demonstrated mixed results. If DSD has failed and the VT or VF continues to persist, the other intervention to consider is administering esmolol at 0.5 mg per kilo bolus. This initially may seem counterintuitive, but remember that a strong risk factor for dysrhythmias is excessive adrenergic stimulation from catecholamines. You know, all that epi you're giving every 4 minutes? Well, it's revving up those myocytes and making them highly irritable. Esmolol should calm down the heart without significantly messing with the peripheral vasoconstriction. Point-of-care ultrasound, or POCUS, is becoming increasingly more common as most physicians are now routinely being trained in its use. This is an amazing tool to have at your disposal. One of the methods a provider can use is called the RUSH exam, which is an acronym that stands for Rapid Ultrasound for Shock and Hypotension. It was developed in 2006 as a way to evaluate the undifferentiated hypotensive patient. It follows a protocolized sequence known as HIMAP. The user evaluates the heart, IVC, Morrison's pouch, the aorta, and pulmonary system. It can assist in the diagnosis of cardiac tamponade, RV failure, PE, LV dysfunction, hypo or hypervolemia, intraperitoneal blood or fluid, aortic pathology, and pneumothorax. This can allow providers to rapidly and more accurately identify reversible causes of cardiac arrest rather than blind guessing. The AHA states that if an experienced sonographer is present and it doesn't interfere with the standard cardiac arrest treatment protocol, ultrasound may be considered an adjunct to standard patient evaluation. If you work in a fancier hospital, you may have access to extracorporeal membrane oxygenation, or ECMO. ECMO can be deployed during cardiac arrest to enhance resuscitation efforts that are refractory to conventional protocols. There are two types of ECMO, VV ECMO and VA ECMO. VA ECMO bypasses the heart and lungs, so it's possible to sustain a life even if the heart is completely non-functional. However, ECMO is only a bridge to buy time for definitive treatment of reversible etiologies. In other words, ECMO is not a cure, just temporary support. If that patient's heart is completely dead and they are not eligible for a heart transplant, ECMO is not appropriate. There needs to be an exit strategy, or else ECMO is essentially a futile exercise. Despite its amazing potential benefits, it's not without some horrible complications like infection, bleeding, ischemia, and vascular injury. The AHA does not recommend the routine use of ECMO for patients in cardiac arrest, but it may be considered for select patients for whom the suspected cause of the arrest is potentially reversible during a limited period of mechanical cardiorespiratory support. The final topic worth considering in your cardiac arrest resuscitation is the nurse-led code. Leading a cardiac arrest resuscitation requires significant cognitive bandwidth. It's incredibly difficult for a single physician leader to run ACLS, intubate, insert lines, determine reversible causes, evaluate the effectiveness of interventions, and so forth. So some resuscitationists, like Scott Weingart, utilize a system where the nurses have a much more prominent role in a code. This nurse-led code model consists of a leadership dyad. There is a designated RN leader who will run all the rote ACLS protocols like rhythm checks, defibrillation, and meds, which frees up the physician leader who can now focus on procedures and individualizing care beyond ACLS. The RN leader also acts as the singular point of contact for the physician to facilitate any needed interventions, and then delegates to another appropriate staff member in the room. The benefits of this model include greater efficiency, reduced chaos, fewer missed things, higher ROSC rates, and empowerment of the nursing staff. Honestly, I have been in codes where the physician is basically a one-man show with no nursing initiative, and so when the doc finally asks, "Hey, when is the next rhythm check?" the recorder says, a minute ago, and also the last epi was 7 minutes ago. That is really unacceptable. If that was your loved one being resuscitated, you would be pissed if the team was not even meeting the basic standard of care. Changing your institution's practice to incorporate the nurse-led code is a low-cost, high-yield way to improve your cardiac arrest resuscitation. Whew, that was a long one. I hope you enjoyed this video. I really had fun researching all the cool things that exist in the resuscitation world. The last update was in 2020, so I'm sure we are about due for the next iteration of resuscitation guidelines. If you found this video helpful, please like and share it with your nursing friends. Thank you for watching, and see you all in the next video.